Dr. Dr. Singh will going to join in a 5 minutes, sir.
So can we go live?
Yeah,
Yes, sir, we can start now.
thank you. Hello, and a very good evening to one and all. I, Dr. Dhammadeep Dabhade, on behalf of Emcure Pharmaceuticals Limited, welcome you all on the occasion of No Thrombosis Live in Box. No Thrombosis Live in Box is the unique scientific initiative wherein we try to learn and understand about the multifaceted landscape of interventional cardiology. And to take the discussion, we have expert faculty with us. It's my privilege and honor to welcome and introduce course director for this program, Professor Dr. Prafulla Kerkar sir. Emeritus Professor at SET GS Medical College and KM Hospital, Mumbai, and Consultant Interventional Cardiologist from Asian Heart Institute, Mumbai. Sir being the former Guidelines Committee Chairman of CSI, Chairman of Board of Studies, Maharashtra University of Health Sciences, former President of CSI Mumbai Chapter, Organizer for CSI Con 2018, former chairman of Pinnacle India Registry in collaboration with ACC, serving the investigator for multiple landmark trials like CREATE, PREDICT, Paradigm HF, Paradise MI, Select, SCORE, Impact MI, Surpass CVOT, and so on. Sir had several hundred publications in the national and international journals and several hundred presentations in national and international meetings, including prestigious orations and awards. Thank you, sir, for joining to this meeting.
Well,
It's yeah, it's my honor to welcome and introduce the moderator for this meeting today, Dr. Vibhuth Pratap Singh, sir. Senior Consultant Interventional Cardiology at Fortis Escort Heart Institute, Okhla Road, New Delhi. Serving the Secretary of Indian Medical Association Academy of Medical Specialties at New Delhi branch, Examiner FNB Interventional Cardiology, National Board of Examinations, New Delhi, winner of prestigious TCT IABP scholarship, Times Healthcare Achiever Delhi 2018 honors role in Rising Star category cardiology. Been the invited speaker at leading national and international conferences, including international faculty at TCT 2017, Denver, USA. Investigator in national and global clinical trials on coronary heart disease and authored several articles and book chapters. Thank you, sir, for joining to this meeting. Our next moderator, Dr. Rajnikant Shastri, due to some personal emergency reason, sir is not able to join for this meeting, who is the senior consultant from Medanta, the Medicity, Gurgaon. Our speaker for this meeting, Dr. Pradeep HN, I welcome and let me introduce him. He is the interventional cardiologist affiliated with the Mediterranean Hospital, Trivandrum and Kollam. He will be presenting with us an interesting case of calcific LAD lesion. Thank you, sir, for joining to this meeting. Our next speaker was Dr. Pankaj Sarkar, consultant cardiologist from Suraksha Diagnostic in Barsat and Birati, Kolkata. Just we got the message from him due to some emergency PCI case with him. He is not probably joining with us for this meeting. And so this will be the agenda for our meeting. For the benefit of audience, let me read the agenda. We'll be having the opening remarks and context setting from our post director for this meeting. Then we'll be having the case presentation from our speaker, Dr. Pradeep, on this case of calcific LAD lesion. and which will be discussed again amongst the director, course director, and the moderator of the meeting. As I just mentioned, the second case will not be presented due to the emergency reason or the PCI case with our second speaker. We will be having the discussion after each case presentation, and then we'll be having the remarks, concluding remarks from our course director, followed by formal vote of thanks from my end. I would like to put a special request to all the audience who had joined with us to put your questions in the comment box. After case presentation, we will take up those for the discussion. So with that, my request, I would like to stop here and would like to hand it over Professor Dr. Prafulla Kerkar sir to take this meeting ahead. Over to you, sir.
Okay, thank you, Dr. Dabade, for those kind words about all of his faculty here. And as I start, I'm happy to welcome Dr. Singh from
Namaskar.
Namaskar. Welcome. I mean, we were just trying to say that you're going to join shortly, and it's nice to have you also in the meeting. And as I said, now, as he's already told you, Dr. Dabade, that this is about discussing live in box PCI cases. And we have been over the last few, I believe this is the fifth session going, and we've covered various topics, right? So the topic for today was radial access PCI in ACS scenario. Okay, especially focus on STEMI and pharmacoinvasive management, the pros and cons of doing a PCI radial access. So radial access, as we know, has become the preferred access these days. Sorry. No. So radial access, as we know, has become the preferred access during PCI over femoral, obviously for obvious reasons that it has less bleeding as an issue, and given the small size of the radial artery and easy compressibility, you can achieve hemostasis very fast and avoid having the local complications that we see in the femoral territory like hematomas or pseudoaneurysms or AV fistulae. All that is not really well known with radial. But having said that, for radial artery cannulation to the entire PCI itself is a matter of a learning curve, and it's only the experts who land up doing it. And it has picked up in a big way. Actually, we Indians started doing radial cannulations and radial artery interventions even before the Western world. And I remember in US also there was a big hue and cry about the fact that they were hardly doing them. And from US perspective, there are cost savings too. Right. So the other advantage is also the early ambulation that you can do, and it becomes a big boon, especially when you have through the femoral access, you have, God forbid, done it, and first time the guy with the prostatism really gets at times retention too, and then you can land up catheterizing a patient at times. I mean, the urethral catheterization you'll end up doing on he's already on a lot of anticoagulants and antiplatelets mainly, and it can be hazardous, of course, and then nothing like being able to get up and stand up and get going within a few hours. But having said that, you need expertise, is what I said. One other advantage why I chose ACS as a scenario is not only the bleeding complications and local site complications, but also the fact that, it is in trials and in the literature today, if you go to see, it is actually reducing mortality compared to the femoral approach. And we all know bleeding is the biggest cause for mortality when it comes to PCI. So that is how it is. And there's enough trial evidence to show that in meta-analysis and so on and so forth. So much so that the latest guidelines from 2025, acute coronary syndrome, PCI guidelines, acute coronary syndrome guidelines of the American guideline, that is the ACC/AHA guidelines, have given it a class 1 recommendation over the femoral approach. So, which is really huge, isn't it? So let's see what Dr. Pradeep has to offer and what kind of case he's going to bring forth, and we can have a good discussion on it. If Dr. Singh wants to make a few comments even before, go ahead, or otherwise we'll not waste too much time and hand it over to Dr. Pradeep from
I
Trivandrum.
think so. Let's move on with the case, and that will be the best option.
Yeah, and then we can discuss it, right? Okay. So go ahead, Pradeep, Dr. Pradeep.
Yes, sir. Good evening, sir. Yeah.
Good
So,
evening.
yeah. So, yeah. Can you please share? Can you, yeah, share the screen? Yeah. Yeah, I'm going to present a case of calcific LED lesion. It was the elderly gentleman. Yeah. Next slide. Yeah. Yeah, it's a 80-year gentleman who presented with unstable angina for past 6 months with recent worsening for the past 2 weeks. Is a known case of hypertension and old CVA. His angio was done outside, which showed triple vessel disease of LAD mid calcific 99% stenosis. Ramus had a osteoproximal 99% stenosis and a circumflex mid 95% stenosis. And his ECG showed a normal sinus rhythm, right bundle branch block with no STT changes, and a echo of ejection fraction 61% with good LV systolic function with a mild MR. Next slide, please. Yeah, this case represents a heavy calcium in LED, which should be modified upfront with the calcium debulking technique. So in this case, we selected ROTA. So it's a ROTA-assisted image-guided PC8 technique. Next slide, please. Uh, in this case, like with a rota-assisted IVAS guided PCA, we used OPN balloon as a calcium debulking technique. Routinely, like we use cutting balloon, but in this case, we used OPN balloon as the calcium debulking technique. Yeah, coming to our case, yeah, this is the cranial view showing LAD mid 99% critical calcific lesion. Yeah, it's a severe calcium in the LED. Yeah, next slide. So upfront we took a rota. So 1.75 bar was taken and almost like 4 runs of rota was taken. But distal lesion was not yielding as we can see in the image. So just a halfway rota was done. Meanwhile, while doing the rota, suddenly the patient had severe chest pain and ECG showed a severe ST elevation with there was a, significant slow flow noted in the LED and the patient had severe chest pain. Yeah, next slide. So after that, 2.512 NC balloon was used for pre-dilatation, but it was not yielding in the proximal LED lesion. So this lesion after rota still with 2.512 NC balloon, it was not yielding. So then we took a IVAS pullback. It's a long IVAS pullback. This was taken after the rota and 2.512 NC balloon, and it showed almost a circumferential calcium, almost 360 degree in the mid LED part. Now the calcium we are able to appreciate in the almost now 90 degree, 270 degree calcium. And while proximal pullback, we can see almost like a 360 degree. Yeah, this is the tightest part we are coming. Yeah, it's a long rota pullback, IVAS pullback. Sorry. Yeah, this is 360 degree circumferential calcium, and the lumen gain was not that much. Yeah, this is the IVAS pullback. It's a little long pullback. This is almost showing the 360 degree circumferential calcium. It's a heavy calcium in the LED. Yeah. 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 Next slide. Yeah, after that, we took a 3 into 10 OPN balloon, and in the mid LED, we dilated it up to 40 atmosphere. So, and the OPN balloon was nicely yielded actually. The lesion was able to yield. And after that, IVAS pullback we took after the OPN 3 into 10 balloon. It showed significant calcium fractures with adequate lumen gain. So, Now in this high waist pullback, we can see that now around 7 o'clock, the calcium break we can appreciate. Yeah, 7 to 8 o'clock. And yeah, around 6 o'clock, 7 o'clock, yeah. So even the adequate lumen gain also is there. Now in the 5 o'clock, we can able to appreciate the calcium fracture. Yeah, now in the 3 o'clock, yeah. Here, like multiple calcium fractures, we are able to appreciate with adequate lumen gain. So OPN balloon helped in this case. Yeah, yeah, yeah. Next slide. Yeah, yes. Then a 3 into 48 Xine's drug-eluting stent was taken and it was deployed. Yeah, it was nicely, the stent was nicely expanded. Then next slide, please. Next slide. Yeah. Then IOS pullback was taken after the stent deployment and it showed MSA of 7.3 mm square. So this IOS pullback, yeah, now we're coming to the stent area. Yeah, yeah, the stent. The stent was like nicely uniform expansion was seen and adequate MSA you were able to gain. Yeah, the stent was uniformly expanded. So rota with OPN balloon, yeah, it helped us. Yeah, next slide. Yeah, and then there was a ramus lesion which was not yielding with the ANC balloon. So 3 into 6 cutting balloon with the guidezilla support was taken. Yeah, next slide. Then ramus was stented with 3 into 32 drug-eluting stent. Yeah, yeah. Now this we can see the LED and the ramus lesion the after stenting the TIMI3 flow. Yeah, yes, we're able to obtain. Yeah, next slide. So, yeah, this is the before intervention. The LED shows tight calcific lesion, mid LED. After procedure, after stenting now, after rota and OPN balloon. Next slide. Yeah, yeah. That's nicely this uniform expansion of the stent and TIMI3 flow we were able to obtain. Yeah. So in this case, like previously routinely like cutting balloon we used to use for the calcium debulking technique, but here like OPN balloon helped us and OPN balloon 3 into 10 after the rota, it helped for calcium debulking in this case. Yeah, next slide. So the lesson learned from this case, severe calcification leads to stent under expansion and is associated with high target vessel failure rates. So adequate lesion preparation is essential for optimal therapy, which can require multiple gadgets and strategies. Intravascular imaging can aid in selection of tools for better lesion preparation. Thank you.
Well, that's very excellent demonstration of how to deal with calcific lesions, and you've come out successful. Now, I'll also hand it over to, before I hand it over to our moderator, Dr.
Yes.
Singh. Um,
Yes.
they, the topic was supposed to have been a radial approach. Now,
Uh,
would you have been able to do this by the radial approach? Let's
no.
discuss a little bit on radial and then go to
Yeah,
the
yeah.
calcium debulking. We did it at
Yes,
the
sir.
last session
Yes, sir.
also.
Yes, sir.
So how would you have approached this case to the radial approach? Would it have been a no-no for you or yes? And if so, how would you have gone about it, is what I'm asking you.
Sir,
So you're
radial,
not a fan
especially.
of radial approach then?
No, sir.
It didn't
We do, sir, but still, especially it's such a calcium. I think upfront we go with femur, femur only we may go, sir.
Okay. So
especially
in
calcium
what
proton.
proportion of cases are you a radial first? Now this guy this gentleman
Uh-huh.
was an
Yes,
unstable angina, but going on for a very long time and
yes,
recently
sir.
worsened angina. So it's sort of, if at all, if you had done some enzymes and if you said that it was an NSTEMI kind of a scenario, and maybe that is also the reason you got slow flow. So that is
Uh-huh.
one thing. Now, but if you had to do it, what kind of a maximum burst size can you take? Of course, you knew beforehand that you wanted to debulk this. And
Yes,
for
sir.
a debulking, what kind of a bird size are you able to take through 6 French versus how often do you resort to 7 French, and what are the new kinds of hardware with Termo themselves makes those, no, the glide sheets and all with an outer diameter and the inner diameter going really big with the outer diameter of a size of a 6 itself, right?
Uh-huh.
Because with an 1.75 burr, even if you had managed to get a burr down, you
Uh-huh.
wouldn't be able to inject with a burr in place for sure, right? Yeah. So by and large, as a general thumb rule, we don't want to do anything more than 1.5 as a debulking. That's
Yes,
what
sir.
it is. That is the only message that one can talk about through radial versus. But the diehard radial fanatics would still want to do it. Now let's ask our expert, Dr. Singh. Now, would you have been, would you would have say it was a STEMI scenario and you
Mhm.
had gone in without the knowledge of what's inside, and you would have gone radial, obviously, right? Or how would you have approached it differently from the radial route? Any tips and traps about that? Then we'll go on to the femoral itself. Yeah.
Sir, I think Dr. Pradeep has a point. The way to the heart goes through the groin. If that is what we always know. And such a complex LED lesion, definitely femoral would have been the first choice. But suppose the radial, what we could have changed. So we have taken a glide sheath. We know 1.25 and 1.5 are compatible with the 6 French. NY catheter, the 1.75 is compatible with 7. Sometimes it requires 8. And these are with NY catheters. That support is important that we have to remember before taking in the thing. Probably I would have gone with, Pradeep, what the whole purpose of ROTA in this case, when we are using 2 or 3 technology. We have got ROTA, we have got IVL, we have got laser, we have got high pressure balloon OPN, and sometimes
Yes,
even cutting balloon. So everything has got some purpose to do. ROTA generally for me in a calcific lesion is to make the way up.
yes, sir.
1.5, 1.25 has got more chances of entrapment. 1.5 is one thing which makes a space for getting my hardware down. So if the radial, it would be an approach would have been a 1.5
Yes,
and taking and making the space. Probably you had the slow flow because the burst size was large, the lesion was not crossed, and when you are doing the rota, the slow flow happened because of the repeated or more of the burst size. And that is a very disastrous complication, even in the ACS or in the non settings. Radial, I would have gone, in suppose it was a acute coronary syndrome settings. Rota in acute coronary syndrome is another ball topic. Vascular lithotripsy is down there, laser is down there. Rota, some people say, but generally in thrombotic lesion, rota is avoided. It would have been a stable setting. Rota, definitely. We could have taken it 1.5, making a space, and then getting the lumen. The whole game is getting the MSAs. You get
yes,
with NC balloons, you get with OPN balloons, you get with the cutting balloons. It is how much minimum area you get with the things. OPN are a high quality balloon. So my approach would have been 1.5 rotor and taking on with the pressure balloons, and that would have been almost thing. But no points, even if the case would have come to me, femoral would have been my comfortable approach because for me, the job is more important. Approach, I think it's okay, it's good. Radial is good, but once you're taking the case, kudos to you. You're taking the patient on and got the patient out. So, okay.
Yeah, that's correct. The I really did not understand your rationale for straight away doing with a 1.75. At least at that mid LED point, it looked fairly tight. So,
mm,
and moreover, if you're saying it was unstable angina going on and all, almost always expect a problem. And as it is, your rota didn't help you to debulk, right? And
yes, sir.
but your guess was right that a bulky device would still go in, not
Mm.
so your OPN did go, right? or you first pre-dilated with a balloon, but it was not an uncrossable, like that kind of a difficult lesion to cross and take a hardware down there, right? So therefore, the OPN. Having said that, that OPN is a good choice. No, it's a cheaper choice. So OPN kind of balloons versus lithotripsy at this TCT conference, there's a lot of talk about, that lithotripsy did not really help as much. Some comparison of for calcific lesion, there were some papers to that effect, means some presentations to that. Not that I attended the TCT this time, but there's
Okay,
a
sir.
lot of news coming from, which is heartening again from our point of view. It is less expensive to deal with calcific lesions, and of course, we could have tried all these things for a calcific lesion. So, doctor, since we are on calcific lesion, we already discussed a lot of things during the
Yes, sir.
last time. Now, Dr. Singh's expertise, because you Delhiites are known to do rotational atherectomy. So,
Yes, sir.
any take on rotational
We
atherectomy?
for last 5 years, we are thinking we have done the stone cutters. So always the thing is always with the heavy calcium things and the things. One or two things about Pradeep about your OPN use. Your choice of wire. What was the workhorse wire which you chose for OPN? Dr. Pradeep, I'm asking you.
Yes, sir.
Workhorse wire for OPN was?
Sir, in this like field FC only we have used, sir.
Oh, no,
No,
no, no,
no,
never
sir.
filter. I thought you will be saying run through or BMW. So
Yeah.
always remember,
Mm-hmm.
very important point about
Mm-hmm.
OPN. They are the high pressure balloons. Always use a support wire, Grand Slam or All Star.
Okay.
Very important because
Mm-hmm.
once the lumen collapse, it will take the
Mm-hmm.
whole system out. And OPN can cause dissection and OPN cause
Oh.
perforation, wire out, the whole
Mm-hmm.
of the procedure will be end. So
Okay.
one very important thing, take the wire to be the
Support one.
support wire. Even
Okay.
if you are doing the procedure, I had just done a case today only. I
Fine.
was doing the procedure with the run through. We had to
Mm-hmm.
take the OPN. We passed on the second wire. That was the support, and then we use the things. Very
Mm-hmm.
important. Always keep it in the mind. Second, your IVUS imaging, the landing size was around 3. Is that right?
Yes, sir. 348,
So,
sir. Yeah.
so remember another very important nugget of using the OPN. When you are using the OPN, the issue is not size matching 1:1. It is
Mm-hmm.
one size under size. So
Mm-hmm.
always use vessel 3. My choice would have been 2.5 and then blowing up to with 4.
Mm-hmm.
Got it? These are the two very important practical tips for breaking of the calcium.
Mm-hmm.
So go with 2.5, then go to 40 if the vessel is of 3. If the vessel is of 3.5, use a 3. So that is a one very important thing which you have to use with OPN. Third point, whenever you are using OPN, never happen to us, but always have the covered stent in the stock.
Yes, sir. Yeah.
And that time you will require a guideline, the wire support and all these things
Mm-hmm.
start coming into play. So in your case, I think these were the three comments which I
Mm-hmm.
filter never,
Oh,
never. These are the wire just to cross the. They are the very flimsy wire. Never, never.
mm,
That.
fine, sir. Okay.
So what about now? He did get slow flow. Obviously, it was also related to the bulky device. So
Mm.
what is your take on using the cocktail for your rota flush? Are you at all using it? Are you?
Definitely, sir. Moment we are using on with the rota, so how the rota will go on? Rota will you will get the system on, get the system up down there. Have the liberal vasodilators. Very important. After a long 2 runs, make it a point. Take a slight check shot. See the flow. If the slow flow is there, leave everything, manage the slow flow. If the artery goes into the slow flow and we are again drilling, it will be a chaos. Slow flow comes, just hold it down, manage the slow flow. Vasodilators, definitely down the tail. Your staff should be ready with the inotropes. You should be ready with all the stuffs for the slow flow things, and probably because of the ACS setting also it played down the things. So very important, preparing the lesion, prepare the lesion, anticipate in the calcified lesion what is next coming, not going what you plan. So in a case, it's like a battlefield, it's like a chess. Planning is okay, but the game will go on with everything that change with the strategy. We had a very interesting case in which Rota was stuck. So another day something, but the thing is that you plan it, but choose as per the case. So very important, the use of the vasodilators, not more burning time, use of the appropriate. Generally, Rota is now in my practice to make a space for taking the hardware down. That is what generally the thing is. So be very prepared for that.
Absolutely. And especially more so that you're using a bulkier, I mean, straight away going up to 1.75. Is that your usual practice? Like what
Not
Dr.
at all.
Singh said, we do
Absolutely
not,
not at all.
I would not, we never do that, meaning it is now it's no longer that adequate debulking. And good old days, even before stents came in, I was associated with rotablation. I was associated with the largest trial airbag those days. So that was the ideal debulking, is when your balloon does not require more than a 6 atmosphere pressure to yield. But those days are gone, right? It's just to create a little crack and then alter the compliance of the artery, and then you're good to go high pressure also post rota today's days and time.
Absolutely.
There
Absolutely.
is to debulk well was okay if it was not such a tight lesion and then you are gone with a 1.75, it was different matter. But that was the main reason I think you got the slow flow. So hats off, you bailed out very well, and you also had the courage to obviously address the second lesion also, which was necessary. In an 80-year-old, you don't want to bring him back just because he got some little slow flow in the cath lab, ST is elevated, but with all that also always you're in praise when there's a slow flow, because yes, it is all to ease us very often. We also discussed slow flow in one of our sessions the last time, right? How do you deal with thrombus there, and how do you deal with slow flow? All these things, none of them really, we think they help. We give a lot of stuff for slow flow in the lab, but generally patience helps out there, and they do come around if you have quickly removed your rota out, etc., right? So that's it. So then we have done all this. We could have discussed more on radial. Had it been a radial intervention, that was what was told to me, that it will be a radial intervention. But it doesn't matter. We repeated all that we did. And it was nice to hear Dr. Singh's viewpoint about how to deal with calcium. So what we haven't done is theoretically, since we are on calcium itself. Now, IVL now in the light of all these, also the trial data coming along and all that, what do you think is the role for IVL as such? Okay, more so because now the latest in the background of latest ECT trial, which was like a IVL, it ran down IVL actually in comparison to the cutting balloons and the OPN balloons to deal with calcium. Yeah. So what's your
So
take? When do you use
my
it?
practice, sir, the vessel size adequate more than three, and the when that is the point where we use. But the important thing about is the cost one. Second, once we have used in the one vessel, the other vessel, the profile becomes not that issue. I think it is a too premature to say level one therapy out. We are in exciting day of calcium because we have got many therapies for the calcium. For any lesion, there will be two or three therapies now. So that we have to keep in mind. But yes, if a non-compliant balloon is yielding, if a high pressure balloon is yielding, it is perfectly. So I was invited to give a talk in CSI, the MP, and they gave me a topic debulking in the resource limited setting, that was Ayushman. In a Ayushman setting, how to deal. And this was much before this TCT thing. So what the whole sole purpose and whole sole things which we quoted down is getting the MSA. If you are getting the MSA with the non-compliant balloon, it is okay. It's okay. You are able to crack it. It is okay. What niche I will is a good technique. So just can't just label it out because Americans, once they said this, we go for this, and they said that, we go for that. That's a wrong approach. Let us see, let us watch how the thing goes on. But it will be many therapies and thing. One very important thing, what we and the Indian resource limited setting, and for you, Dr. Pradeep, once we are
Yes, sir.
dealing with a calcified lesion, always take two orthogonal shots.
Mhm.
See the balloon if one is to one. If it is constricted in both the views, that means the lesion is not prepared. If it is constricted in one view, the lesion still can be addressed. And that is what at our the CTO chip side, we had made algorithm for the same thing, that in the resource limited setting where the imaging is not down there and you've got some things. So take these two orthogonal views for the calcium. In nutshell, all the therapies are important. They have got different side, different purpose. And sometime now what we are seeing the difference, and say almost a decade back when I started the practice, now what the difference is, we are using more than one devices in one patient, and we are using it liberally. And each device is giving something. So yesterday case, rota we did, cutting we did, not yielding, got the OPN on, yielded. patients we have seen, the patient was taken up for the ACS, calcium not yielded. Next day we took it for the IVL, it yielded. So every patient will have a different subset. So not to premature go for that, but yes, definitely IVL has taken a dent after this TCT whole trial thing.
Yeah. So that is it. Acha, the other thing you also used was imaging, and imaging is quite necessary when we are dealing with this. In fact, from a theoretical academic point of view, imaging has finally got a class one recommendation also in this ACS guidelines. Even during ACS, there's a huge role for imaging, and you showed beautifully all the IVIS images and the cracks that had come along with OPN balloon. So those kind of cracks also we see with IVL, but with OPN that such cracks can be obtained. That was an excellent demonstration. Well, so that is it, I guess, right? We have anything else to discuss? I don't know. Are there any questions from the
I think
delegates?
one thing I was approached was slightly, Dr. Pradeep, your stent came too much osteoproximal. Is that thing I was not able to delete on the uh, was the proximal landing of the stent
Yeah,
was
proximal landing, sir. Proximal landing. Proximal to mid,
proximal
sir.
landing.
3 into
Why
48.
not Ramus going for the first with the Ramus and then coming with the because if suppose I thought it was more of osteoproximal. Okay, no issues.
Okay.
Okay. So, yes, so what I was also saying is that are there any questions from the delegates that we could take? Otherwise, I guess we are done, right? So we have had some excellent learning in the case. Every
Okay.
case is a learning, of course. And thank you, Dr. Pradeep. It was a very nice demonstration of what happened, and you really documented everything, which was also important, including the slow flow was there for us to see. So, so now
Thank you, sir.
different challenges, different problems, we can deal with it. Maybe the next time we could have a radial PCI as the topic, and I suppose we could get Dr. Singh again, please, Dr. Damandeep. Yeah, we can get his
Sure,
experience
sure.
on
Yes.
radial PCI, and
Fine, sir.
hopefully there will be interventionists who do that. And meaning, especially what has happened is recently I was chairing a session wherein a radial PCI was attempted for a STEMI scenario, in a STEMI scenario, and lo and behold, the RCA was anomalous. Okay. So RCA was anomalous, but he just kept on trying, and then eventually he managed, or no, he didn't manage. He then changed over to femoral. What is very important message is that when it's a STEMI scenario, don't be on your ego about being a radialist. Okay, I know, but there is willingness to shift, from whatever problems that you come across. Now, anomalous RCAs, you never know about them. Again, you might get a lusoria. What I mean is that you might get an ARSA, that is aberrant right subclavian, coming from the descending aorta. They're repeatedly going into descending aorta, not to hang on that, right? And a changeover to either the left radial or this thing does matter, to femoral that way. So we could even discuss the alternative radial, distal radial, ulnar PCI, etc. We could do that at a later point in time. But yes, it was nice to have you all today. Thank you so much, Dr. Singh.
Thank
And
you
I'm
so much, sir.
sure the
Thank you,
audience
sir.
is
Thank you,
also
sir.
educated with this particular case. And over to you, Dr. Tamandeep.
Yeah. So we are nearly at the finish line of this meeting. But before we conclude, let's express our gratitude to all who made this scientific program possible. I would like to express my deepest gratitude to our course director and moderator for course director Dr. Prafula Kelkar sir and moderator Dr. Vibhuti Pratap Singh sir for sharing their knowledge and their expertise with all of us today. Then I would like to express my deepest gratitude for our speaker today, Dr. Pradeep sir, who presented in front of us a very insightful case, and we had a very dedicated discussion around the case. And I hope all the audience who watched this case presentation must be benefited out of this presentation. And that's why I actually thank to the audience to be the part of this meeting and who witnessed this meeting. Last but not least, I would like to express my gratitude entire team from our Emcure sales, marketing, and medical who tried their hard to make this meeting a successful and cheerful manner. Last but not least, I would like to say once again a very good night and a very good time ahead. Thank you. Thank you for joining this meeting.
Thank you.
Thank you.
Thank you, Dr. Pradeep.
Thank you, sir.
Thank you, Dr. Sharma.
Thank you,
Thank you,
sir.
Alex.
Thank you.
Thank
Thanks.
you all.
Thank you.
Bye.
Thank you.